We want to thank everybody for joining here to hear kind of like a job talk seminar today of Dr. Jessica Montoya. Jessica is a postdoctoral fellow working largely at the HIV Neurobehavioral Research Program, but Jessica's research really goes in many different areas throughout the community. She's doing a variety of very interesting work that you'll enjoy to hear a lot about. A really fantastic opportunity has come available for Jessica, and so we are acting quickly to make this happen. She was nominated for the Excellence Search for Diverse Faculty in Health Sciences at UCSD, and the goal of this program is to build a diverse faculty and develop a diverse and inclusive community of scholars to enhance our academic and research missions. And so Jessica has agreed on relatively short notice to give a lecture today. Her lecture, as you can see, is an integrated incentive-based treatment to optimize HIV treatment engagement among persons who use methamphetamine. And thank you so much, Jessica. Really excited to hear your talk.
Sorry, okay, I was muted. Thank you for that introduction, Dr. Taper. So let me see if I can control the slides. Yes. So for today's talk, I will be giving an overview of my background in terms of my training. And then I will be talking about 4 areas of my research that are most relevant to my proposed program of research going forward. And to illustrate my proposed program of research, I am going to give an overview of 3 grant applications that I have in process that we will be submitting in May 2020, so just around the corner. So my research background actually began during my undergraduate years at Princeton University. I was very fortunate to be working with various investigators who were doing neuroimaging work. And I had a very basic senior thesis project where I was looking at grasping-related behaviors and mapping them on to various areas of the human posterior parietal cortex. So it was very basic in terms of the complexity of the task itself, but the methods were quite complex. And that put me on a really good trajectory to land a research assistantship at Yale. And there I really fell in love with the field of addiction research. I did 2 different areas of research while I was there. I did a lot of the imaging research as related to attachment of mothers toward their children who also use illicit substances. So we are doing a series of neuroimaging studies related to that. But we were also investigating what was then referred to as pathological gambling. It was an impulse control disorder at that point in time, and we were trying to make the case that it was more of an addictive disorder. So that really solidified my decision to pursue training in graduate school. And I was very lucky to earn a position at the SDSU-UCSD Joint Doctoral Program, where I've had a lot of research experience, and I'll be talking more about that today. And then I was recruited by Dr. David Moore to be a postdoctoral scholar on NIDA T32. So this has resulted in numerous publications to date. I have 9 first authored and 2 senior authored papers. I have several manuscripts under review currently, a couple of book chapters, and numerous national conference presentations. And throughout my training, I have been very fortunate to receive various sources of funding, beginning actually when I was an undergrad. So I was supported by a Gates Millennium Scholarship that's awarded to ethnic minority students who demonstrate leadership in community service and who also are eligible for federal Pell Grants. I received a couple of grants to support my senior thesis as an undergrad. And then during graduate school, I was supported initially by the San Diego Fellowship, and then I earned a NIMH diversity supplement to study successful aging among people with HIV. And then I had a couple of grants to support my dissertation work. And then currently, in addition to my T32, I have a R25, I'm a co-investigator on a grant to support work related to HIV and STI awareness prevention among rural American Indians. And I also am involved in a study looking at disparities in African Americans and using texting to reduce disparities in HIV care. Although today I'm focusing on my today I'm focusing on my research, I have also been trained clinically. So during my doctoral work, I worked in several clinics at the VA San Diego healthcare system. I also completed my clinical internship here. And currently I provide clinical coverage at the HIV Neurobehavioral Research Program, and I am licensed as a psychologist in the state of California. I make note of this because I think of myself as a clinician, and I always want my research to be clinically relevant. All right, so I want to talk about my previous research and how that set me up to really move forward with the program of research that I'm proposing now. All right, so there's 4 areas of my research that I want to highlight. This is by no means exhaustive. I have done a great deal of work as it relates to aging and HIV, but moving forward, I think these are the most relevant themes that I want to convey today. So I've examined the interplay of HIV and methamphetamine, where I have picked up very advanced statistical quantitative approaches. I focus on the treatment adherence among people living with HIV, where I've been able to evaluate randomized controlled trials. I have done qualitative methods to examine patients' perspectives of adherence difficulties and intervention adaptations. And then I am strengthening a community academic partnership to really address HIV and STI among rural American Indians. At the bottom of the screen, I have put the HIV care continuum. And this is really a good public health tool that guides my work. We have approximately 1.1 million people in the US who are living with HIV. And the goal, the public health goal at least, is to have all of them have suppressed viral load. Essentially what that means is that they have been identified as having HIV, they've been linked to care, prescribed antiretroviral therapy, and are adherent to the point of being able to suppress their viral load. When someone has suppressed viral load, essentially their risk of transmitting HIV to other people is 0. So that's the goal. Unfortunately, we haven't hit our public health targets. So that has called for a lot of initiatives, such as the Ending HIV Initiative, to really help us figure out how we can make sure that everyone who has HIV is aware of their status and is also linked to care. So in regard to the interplay of HIV and methamphetamine, one of my main findings was that many people living with HIV initiate or persist in methamphetamine use after receiving an HIV diagnosis. In fact, in our cohort, we found that 20% of people didn't start using meth until after they tested positive for HIV for the first time. And when we look at density of use, which is how many grams of meth are people consuming on a day that they use, we found that, not surprisingly, younger people tend to use more, but also for both age groups, following their first HIV positive test, they actually increased their use. On one hand, it's not so surprising because people do develop tolerance, but on the other hand, it is because we would hope that when someone receives a diagnosis like HIV, that their substance use would be moderated, but we didn't find that this was the case. In a very statistically savvy investigation that involved a 5-year span, so repeated measures, we found that transient changes in affective distress among persons with HIV were greater among those who had current major depressive disorder, not surprisingly, given that it is a mood disorder. But we also found that briefer durations of abstinence from meth, as well as using a higher quantity, was also associated with greater changes in affective distress. And so I think both of these papers really highlight the potential value of assessing substance use among persons living with HIV, but also it highlights the need to do so across the lifespan. One of my motivating factors for choosing San Diego State, UC San Diego for grad school was the opportunity to work on the ITAP study, which stands for Individualized Texting for Adherence Building. This was a text message system that was really intended to promote medication adherence, and it involves daily interactive text messages that are sent to a participant at their preferred dosing time. Over the years, ITAP has been adapted for various groups experiencing adherence difficulties. That's inclusive of people with HIV as well as those at risk for HIV. And the message content can really be grouped into two major domains, which are messages that are meant to be health promoting and other messages that are just meant to be fun and also increase some like variety in the messaging that people are receiving. So we call those the factoids. So people generally receive these daily and they're interactive in that we are asking for a response. So for the ITAP study that was geared toward people who use methamphetamine, they might receive a message that reads, "You can have fun and take your meds, take your small white pill now." And then this person said A, that they took it, and then they received a reinforcement message. There were various components of the study, so people are non-responsive, they get a follow-up text after 3 non-responses, 5 non-responses will initiate a call from an RA, and then various studies also assessed for mood or methamphetamine use by text message. And so for one conference, we presented this data that I think is really compelling, where we saw that increasing engagement as measured by the level of responsiveness to text messages was associated with better antiretroviral therapy adherence in the group that received the ITAB intervention, but not in the group that did not receive the personalized reminders. And so I think that this really makes the case that engagement in any sort of intervention can be a proxy for overall adherence to a treatment program. So those who are less engaged, surprisingly, were less adherent. Those who are more engaged were not so surprisingly more adherent. But it also speaks to the use of the ITAP system as an assessment tool. Although we did assess for methamphetamine use in the ITAP methamphetamine study, our goal was not to necessarily intervene on meth use per se. But surprisingly, we did find that there was an effect on people's meth use. So those who received the individualized texts for medication adherence reported fewer days of meth use. The median was 14 compared to those who did not receive the personalized reminders. They reported using on average 22 days. And so I think one takeaway message here is that patient engagement in their medical care, in this case HIV treatment, may often moderate substance use. So you don't necessarily have to intervene on substance use to have optimal HIV outcomes. The next line of research that I want to cover relates to patient perspectives of their adherence difficulties, and which we have then used to inform intervention adaptations. So for all of these for all these projects here, what we did was we conducted a series of focus groups where we asked people about their adherence difficulties, but we also presented them with an overview of the ITAB or other sort of intervention and asked them for their input. So we did this for the ITAB methamphetamine study, another intervention to promote physical activity, and then another one where we were promoting both the Mediterranean diet and physical activity. So an example of how we might use participant feedback to adapt the message content is shown at the bottom of the screen. So in the ITAP study, in our focus groups prior to the implementation of it, a participant gave us the feedback, a lot of us are religious and I didn't see any kind of spiritual messages. That prompted us to then develop messaging content related to spirituality. And so one example message that we had related to spirituality read, God grant me the serenity to do this. It's time for your, and then they fill in their description of their medication. Currently, I am helping coordinate the IC Change study, which is done in partnership with the Family Health Center of San Diego. For this study, we are focused on health disparities that African Americans face in regard to HIV care. So despite being a smaller population in San Diego, they face heightened disparities in HIV care, so they're less likely to be virally suppressed. So for this study, we also conducted focus groups before we rolled out the study. And a participant told us in regard to the message content, it sounds to me like you can kind of gauge the zero disclosure to high disclosure type person, and then, you know, go from there. And this has led us to now think about ITAP in terms of levels of disclosure. So we may have the low disclosure participant who wants to receive the messages, but doesn't want there to be any reference to having HIV or any health condition. And then we have the high disclosure, which represents a participant who doesn't have those same privacy concerns. So for one message in the low disclosure, they might receive, you've been doing great. A high disclosure participant would receive something that alludes to a health condition. So you've been doing great with your adherence. Neither one is technically very high disclosure, but I do think that the choice puts people more at ease in terms of receiving content and matches their preferences. So a foundational component of this is that it's really allowed us to appreciate the various patient preferences regarding intervention content and delivery. And it also is a nice illustration of how you can use qualitative methods to maximize the fit of interventions to fit the group that you're wanting to target. All right, so the fourth area of research that I wanted to cover is my work with rural American Indians. So as I alluded to with the HIV care continuum before, our goal really is to prevent more people from being diagnosed with HIV. And if we look from 2012 to 2017, so this is based on the CDC's last surveillance report, we see that overall there has been a decline in new HIV diagnoses. So that's represented with the yellow arrow pointing down at 11% decline. And if we just do kind of a gross examination across various ethnic minority groups, we see that we're doing better than we have. Although what's really shocking is the percent increase for American Indians, Alaska Natives. So American Indians, Alaska Natives make up a very small population in the United States, but yet represent a crucial health disparity in that for whatever reason, they're not seeing the same decline in HIV cases. What's also concerning is that 18% of American Indians living with HIV are unaware of their status. And this compares to about 13% of the general population living with HIV who are unaware of their status. And 20% of newly diagnosed American Indians, Alaska Natives meet criteria for AIDS. What this indicates to me is that they are later to test for HIV. And so because they're later to test for HIV, their HIV disease has become more severe, more advanced, where they now meet criteria for AIDS. So this is an alarming disparity, which prompted a team of investigators, including myself, to propose a grant that was fortunate to get funding through the National Institute of General Medical Sciences. What's unique about this team of investigators is that we all are American Indian. and we all have an interest in really helping to intervene when it comes to these HIV new diagnoses. So we partnered with the Indian Health Council in Southern California, which is basically 9 tribes have come together to pool their resources to provide health services to their communities. So on the map here, I've kind of graphed out where those various Indian reservations are located. So aims, we are about in year 2. Year 3 will begin this fall in this study. But for the first 2 aims, we conducted key informant interviews and focus groups to elicit community level HIV STI risk perception and total and continuous STI prevention. At the same time, we were also hoping to identify various platforms such as technology-based interventions, community outreach, health fairs that may be appropriate for delivering HIV and STI prevention to these tribal communities that they perceive as feasible and acceptable. In the second half of the study, we were focused more on the individual and social structural levels that affect HIV and STI knowledge, on access concerns in terms of receiving. Lastly, identify the infrastructure, the resources needed to promote the 2 HIV STI prevention platforms that were identified as being viable for these tribal communities. So as I mentioned, this study is ongoing, but I did want to present some preliminary data that has come from our focus groups. So one theme that has risen is there just being a generally low perception of HIV and STI risk in these communities. One exemplar quotation reads, "Because the young people think, but that was your time. They've got this attitude. Well, it's all good." And I think that this probably represents the changing landscape, healthcare landscape of HIV. So in the 80s and the 90s, it was really considered a death sentence to treatments. But now with the widespread use of effective antiretroviral therapy, the perception of risk has gone down, even though that may not actually reflect the current risk in this community. I also want to speak to this theme of trauma that we picked up on. So someone in a key informant interview said, "There's general trauma. So there's a lot of practice in not thinking about that. So I have to function in some form or manner. And I can't think about all those things. I need to be distracted. Either I'm going to do that with food, I'm going to do that with TV, I'm going to do that with some form of substance or behavior, or all of the above." And so distraction away from trauma is an issue. And I picked out this quote as being relevant because I think the idea of generational trauma is quite complex. In the American Indian community, prior to the 1978 Indian Child Care Welfare Act, many American Indian children, I think as high as 35%, were forcibly removed from their homes. And so they grew up many times away from their family, away from their culture. And this has led to subsequent trauma being passed on through the years. I think it's complex, it's probably understudied and not quite fully understood, but I think it's a relevant theme in this community. And I remember being in a focus group and hearing from some participants when we asked about this generational trauma, like skepticism or not quite sure if they wanted to talk about it with us. And one of the focus group members said, "Oh, it's okay, they're Native too." And once they recognized that Tommy and myself were American Indian, there definitely was this ease, or at least this willingness to start speaking about these complex issues. I think that would have been possible with any investigator who builds a trusting relationship and has good rapport with people of this community. But I do think there is some value in Tommy and I both representing people who also are American Indian and who've had some shared experiences. But overall, I think this does speak to the importance of strengthening a community academic partnership, especially when we're trying to identify strategies for delivering prevention services that there just may not be awareness of the need for, or there may just also still be a lot of stigma surrounding. So to summarize, the research that I think is most relevant to my proposed program of research moving forward has focused on the interplay of HIV and methamphetamine. I've focused much of my efforts on promoting treatment adherence among people living with HIV, particularly those who use methamphetamine. I've done a great deal of qualitative work to understand patients' perspectives of adherence difficulties that then inform intervention adaptations. And then my ongoing work is with rural American Indians to address HIV and STI. All right, so now I will move on to my proposed program of research, but I also want to give the opportunity for any questions at this point. Okay, I don't see any, so I will move forward. All right, so moving forward, I have 3 grants that are currently in progress for May 2020 deadlines. The first is a NIDA K23 that I will talk about first. And then I'm also applying for 2 Center for AIDS Research Supplement grants that are related, but also an extension of the work that I propose in my K23. So for my K23, I am shifting gears by focusing more and more on implementation research, which is great timing with the newly founded UCSD DISC Center, Dissemination and Implementation Science Center. So I'm happy to see the infrastructure that is now available. But with implementation science, my focus here is really on using tested strategies to adopt and integrate evidence-based treatments into clinical and community settings. So, you know, in my previous work, for example, in ITAP, we've shown that in research studies that is quite effective. But trying to move that toward real-world settings is a new challenge. And one that the dissemination and implementation research investigators have tried to establish a rigorous study of. And so I'm hoping more and more of my research is in this domain. So the title of my NIDA K23 is an integrated incentive-based treatment to optimize HIV treatment engagement among persons who use methamphetamine. So when I first started conceptualizing my K23, I was talking to various local providers here at UCSD's Owen Clinic, as well as providers at the Family Health Center of San Diego. And at that time, I was wanting to address opioid use, given that there is a big public health push right now to help combat that crisis that our nation is facing. But overwhelmingly, I got the response that clinicians generally feel well-equipped and supported right now to treat opioid use disorder because it's becoming a bit easier for them now to be able to prescribe medication-assisted treatments for opioid use. But methamphetamine is a completely different story. Many providers said that it was highly prevalent and that they just didn't feel quite equipped to effectively treat meth. And so this inspired me to fill that gap, especially because methamphetamine is highly prevalent in our community of people living with HIV. And when we look at the HIV care continuum, we see that meth is thwarting any efforts that we're trying to make in terms of ending the HIV epidemic. So people who use meth have a greater risk of HIV seroconversion. They have delayed HIV testing for diagnosis. They have a harder time being linked to care and also being retained in care. And they're more likely to have detectable viral load, meaning they're also more likely to transmit the virus to other people. So there's really this need to intervene on meth use. And luckily, substance use disorder treatment seems to be a viable answer. So among people who use meth, engagement in substance use disorder treatment is associated with a threefold greater odds at being adherent to antiretroviral therapy. So it really seemed like we need to do a better job of making substance use disorder treatment available to those who are needing it. So in my background search, time and time again, I found that contingency management is by far the most effective treatment for methamphetamine use disorder. There have been numerous studies trying to identify an effective pharmacological treatment for meth use disorder, but all of those studies really have not found a treatment with a robust effect. So currently, NIDA only recommends behavioral treatments for meth use disorder. Contingency management has the largest effect size, so across multiple meta-analyses, the Cohen C ranges from 0.41 to 0.68, with relapse prevention and CBT achieving the next largest, but substantially lower effect sizes of 0.32 and 0.28 respectively. Many people were aware of how great contingency management was within the field of HIV. They decided to adopt some of these principles to develop incentive-based treatments to improve antiretroviral therapy adherence. And among interventions to improve antiretroviral therapy adherence, these incentive-based treatments have emerged as showing some efficacy, although I will say the results have been mixed. And when I've dived into that literature, you really see how principles of operant conditioning aren't always adhered to in these interventions, which has greatly influenced whether or not they were efficacious. So some components of contingency management are that you provide immediate positive reinforcement, and that's not always routinely done in these studies. And then you have to also be very mindful about the incentives that you provide in these treatments. So there's not always that clear match, whether the reinforcement has any value to the group that's being targeted. Another thing I want to note, though, is among the interventions to improve HIV outcomes, the integration of substance use disorder treatments and HIV care have really shown strong promise. Instead of being siloed and not housed within the same center, the integration really allows people to have easier access to both treatments and results in better outcomes. I do want to make note, though, that the integration of substance use disorder treatment and HIV care requires some thought. It's not just something that happens organically. People who deliver substance use disorder treatment have to be familiar with HIV care and vice versa. So there are many times things that need to operate in the inner context of this setting to make sure that providers are on the same page as it relates to both substance use disorder treatment and HIV care. And this ties into the urgent need to build translational considerations into the development and adaptation of treatments. So, for example, if there's a substance use disorder treatment that works but doesn't fit within the setting of HIV care, it doesn't really do us any good in the real world. So we need to adapt our substance use treatments to fit the settings in which we want to roll them out. So the aims of my K-23 are first to identify the resources required to implement incentive-based interventions such as contingency management in settings serving people with HIV who use methamphetamine. So this we will do a mixed methods approach where we will work with providers, staff, and clients in various healthcare settings in Southern California to really understand some of the barriers and supports to for these settings to adopt incentive-based interventions. My theory is that we move forward and we adapt contingency management, but then no one actually wants to use it. So we are trying to build in translational considerations from the start. In aim 2, the goal is to adapt contingency management to duly target reductions in methamphetamine use and to promote antiretroviral therapy adherence, which we coined CM plus adherence. We want this to be desirable and acceptable to persons with HIV who use methamphetamine. In aim 3, we will conduct a small pilot to evaluate whether the integrated incentive-based treatment is feasible and acceptable to persons with HIV who use meth compared to contingency management that only targets reductions in meth use. So the actual protocol will be informed by aims 1 and 2, some ideas of how we think this protocol will shape up are provided on this slide. So contingency management involves rapid on-site testing for methamphetamine, and this is typically done 2 to 3 times a week. In terms of the clinical settings, in our local setting, twice weekly may be what's more feasible. And then we propose to measure antiretroviral therapy adherence based on text message response, which although is not an objective measure of adherence, our preliminary data show that text message responsiveness is correlated with overall adherence. And then we're proposing to use what we refer to as the fishbowl method, which is when participants demonstrate the target behavior, such as being abstinent from meth, they get to draw from a bowl containing 500 cards with 50% of them associated with a prize. So the prize is not guaranteed. It's really just giving yourself the opportunity to draw from this bowl. And we're using the variable magnitude of reinforcement procedure, where there are prizes of varying magnitudes. So some of the prizes might be something as simple as bus pass, all the way up to something that's $100 in value, maybe something like wireless headphones. And then of importance, participants have increasing opportunities for winning prizes with sustained abstinence from meth or with sustained antiretroviral therapy adherence. So table 1 describes the reinforcement schedule. So we're proposing a 12-week protocol. Twice weekly means that there would be a total of 24 sessions. Session days may happen on Monday and Thursday. In the contingency management only arm, they could get up to 8 draws from the fishbowl if they were to have 8 consecutive negative urine test screens. And the maximum total prize amount would be roughly $364. With the contingency management plus adherence arm, they would be able to get a max drawing of 4 draws from the fishbowl for having urine toxicology being negative. And then they would also get draws for being adherent. So combined, they would have roughly the same amount of draws as a contingency management only arm and earn roughly the same amount with 377. We wanted the arms to be comparable in potential earnings because we didn't want to just show that more money equals more effectiveness. We wanted these to be comparable. This is a pilot, so we're focused here on feasibility and acceptability. All right. So another grant that we have in the works is a Center for AIDS Research Administrative Supplements, where we are also proposing to adapt contingency management to decrease methamphetamine use. But here we are focused specifically on people who are on buprenorphine for opioid use disorder. So the focus is on these on persons who co-use opiates and meth. So as I mentioned, the integration of prevention treatment services for HIV and substance use disorders shows promise for achieving optimal health outcomes. As it relates to opioid use disorder, medication-assisted treatments like buprenorphine have been shown to improve not only sustained abstinence from opiate use, but also has been shown to improve HIV outcomes. However, when we look at those who are on MAT, we see that one barrier for sustained use is dual use of methamphetamine. As I mentioned in my previous application, contingency management is the most effective treatment for meth use disorder. So what we're trying to figure out is how do you most effectively treat co-occurring opiate and meth use disorders within HIV primary care clinics. So if we look at UCSD's own clinic, about half of the patients who are prescribed buprenorphine for opioid use disorder have co-occurring methamphetamine use disorder. And when we look at those who are not retained on MAT, about most of them fall out of treatment within the first week. So the idea is that something like contingency management, where there's this immediate positive reinforcement for abstinence, might be something that kind of hooks them in initially to aid with retention. So the first aim of this proposal is to adapt the contingency management protocol for implementation at UCSD Owen Clinic for co-use with MAT. So in this aim, we're going to work primarily with the UCSD Owen Clinic providers and staff to make sure that the MAT plus contingency management protocol is acceptable, appropriate, and feasible compared to delivering only MAT. And then in aim 2, we plan to conduct a 12-week pilot test of medication-assisted treatment with contingency management. And our hypotheses are that those that engage in medication-assisted treatment with contingency management will be more likely to be retained on MAT, and they will also have lower rates of missed primary care appointments at Owen Clinic. So in aim 1, we propose to work primarily with the Owen Clinic personnel, and this will be in the form of meetings to review and refine adaptations to provider practices. So there's a lot that's involved in rolling out a new treatment at a setting. So this would be inclusive of provider training and the interpretation and discussion of substance use disorder screening results, including being able to provide a rationale for referral to contingency management for patients who meet eligibility criteria. It involves providers being confident in navigating the linkage to patients to contingency management, tracking of the completed contingency management clinic appointments via the EHR. We want there to be collaboration between HIV primary care and contingency management providers. And we do plan to leverage an existing protocol of contingency management that's already been evaluated in HIV primary care clinic. Again, the outcomes are acceptability, appropriateness, and feasibility. And then in aim 2, we are targeting persons with HIV who are prescribed MAT for co-occurring methamphetamine use disorder. So they will participate either in a 12-week medication-assisted treatment with contingency management or receive medication-assisted treatment only. And then we are looking at the outcomes of sustained use of MAT and then the no-show rates to HIV primary care appointments. And those can all be gleaned from the electronic health record. All right. Lastly, I want to review a CFAR Ending the HIV Epidemic supplement that I, along with David Moore, putting together as multiple PIs. The title is Treating and Preventing HIV by Supporting Medication Adherence with Individualized Messaging. So if I've not made it clear already, adherence is required for antiretroviral therapy to effectively suppress HIV viral load among people living with HIV and adherence is required for those who are at risk for HIV who are taking PrEP to prevent a new HIV infection. We have done numerous ITAP studies now to show the efficacy for ART and PrEP adherence. So the goals of our current proposal are to sustain ITAP at a community-based organization, the LA LGBT Center, that has already implemented ITAP or HIV prevention in a research study, and to also prepare for the implementation of ITAP for HIV care within that same setting. So this is the EPIS framework that has been developed by Gregory Ahrens in our department. And implementation frameworks can really help guide the implementation process. So for here, there are 4 well-defined stages of exploration, preparation, implementation, and sustainment. In the current iteration of EPIS, this is perceived as cyclical in nature, recursive in nature, meaning that you may be at implementation, but if things change in the inner and outer context, you may have to return to the preparation stage and vice versa. The outer context reflects things that are happening outside organization setting. So things like policy, like the ending HIV epidemic, or CDC guidelines for care. It has factors such as the inner context that may influence implementation process, such as changes to people's workflow. But it also makes note that the features of an intervention itself can impact the implementation process. So for us, ITAP, we think is, well, we know from research is effective, it's adaptable, and relatively low complexity. But one barrier may be whether or not it can be integrated with the EHR. And then the EPIS framework also identifies bridging factors, which help bridge the outer and inner context factors that influence implementation. So we're using the EPIS framework in this study, but I should also mention it's the guiding framework for the other applications that I've reviewed today. So the aims here are to identify the determinants of implementation and sustainment of ITAP at the LA LGBT Center. So we're going to use the mixed methods approach. And our hypothesis is that there are going to be specific inner context factors, such as available workforce and workflow disruption, that will be identified as barriers to implementation and sustainment of ITAP. And then in aim 2, like the other studies, we're focusing on acceptability, appropriateness, and feasibility as our implementation outcomes. And then the exploratory hypothesis currently, and it's the current iteration of this draft, is that we would like to focus on client outcomes and hoping that those who receive ITAP are more likely to have undetectable viral loads or a lower HIV PrEP, or sorry, I think that's correct. Okay, and there will be more people who are adherent to PrEP compared to standard of care. So for this project, we have been working on our implementation research logic model. So our general blueprint for implementing and sustaining ITAP at the Los Angeles LGBT. On the left-hand side, you see determinants. So this reflects our EPIS framework identified determinants. So the outer context, inner context, bridging and innovation factors. Those factors that we think will be supportive of implementation are denoted with the plus sign, and those that we think will be barriers are denoted with a minus sign. And then the color coding of the font indicates a causal pathway. So for example, we think that implementation will disrupt the workflow. And so as an implementation strategy, we think that that will require training and educating our stakeholders in order to confer high acceptability, appropriateness, and feasibility. And the mechanisms of action are denoted on the third column, which we think involves building knowledge skills as well as behavioral regulation processes. So this sort of framework really makes sure that we are going about this project in a very systematic way that's informed by theory as well as research. So to summarize, I have 3 grants that are being submitted in May. One is an ITAP 23, and then there are 2 CFAR supplements. They all are focused on how best to treat methamphetamine in the context of HIV, to support treatment engagement, and to advance national efforts to end the HIV epidemic. All of these studies are informed by implementation science, which I think is a unique niche that I can fill in the department. I know that there are other people with expertise with implementation science, but I think I have the unique focus of wanting to implement treatments for substance use in settings serving persons living with HIV. So with that, I thank you all for your attention, and I welcome any questions.
Great. Wonderful presentation, Jessica. Thank you so much.
You're
Yes,
welcome.
we do have some time for questions if anybody would like to ask Jessica. I could ask just one. What are some of your biggest concerns with implementing contingency management in general?
Yeah, I think that there are many attitudes from, at least from the provider and leadership, where there are many people who may view contingency management as rewarding people for doing something they should already be doing, which is not using meth. And so in my proposals, we're really trying to develop implementation strategies that target the provider level, because I do think that that's going to be a primary barrier. Whereas the literature really suggests that in terms of patient preference, contingency management is viewed very favorably. It's usually the inner context that's not supportive.
Great, thank you.
So hi, Jessica, it's Greg Ahrens.
Hi, Greg.
Really nice presentation.
Thank you.
So you brought up the EPIS framework, and so we've been thinking a lot about these bridging factors, and I'm thinking about the costs of something like contingency management and where that funding may come from. And I just wonder what your thoughts, like you're working in many different settings, including like reservations, including community clinics and UCSD clinics. And so what are your thoughts about how that kind of policy context might relate to the ability to have funding and policy support for something like contingency management in these different settings that you're working in?
Yeah. So my understanding so far regarding policy around contingency management is that many of the settings serving persons with HIV are eligible for Ryan White funding. And Ryan White funding doesn't have any rules against using Ryan White resources for something like contingency management. So I do think within Ryan White's settings, there's a little bit more leeway for implementation of contingency management. But in other healthcare settings, I do think that the financial part of contingency management is a harder sell. If we look at the cost effectiveness, it is actually a cheaper intervention than a lot of existing treatments for substance use disorders. So if I think about cognitive behavioral therapy, it actually requires a clinician that's trained at a higher level and not necessarily cheaper. So contingency management, the studies that have done cost effectiveness has actually shown that it is relatively low cost compared to medication-assisted treatments. There is a move within the state of California to allow the use of Medicare funds for contingency management. That was not yet voted on, so it's in the works. Not sure if it will be approved, but there is some movement toward increasing access to contingency management. I think that that will probably be spearheaded by states who are more impacted by meth, and California happens to be one of those states. On a national level, I should note that the VA has been an early adopter of contingency management and has done a great deal toward increasing access to contingency management for veterans.
Great, thank you.
Very nice.
Hey, Jess, it's David.
Hey, David.
Excellent presentation. Really shows incredible breadth and depth of work that you've done. Can you talk a little bit about how your experience doing qualitative work kind of with individual level feeds into implementation science and how those two might dovetail together?
Sure. I think that they are comparable processes. So with our focus groups today, we focused primarily, at least in our publications, on the client level of making sure the intervention content fits the express needs and desires of the group we're trying to target. And so we've used that feedback to aid the adaptations we've made. In my proposed implementation research, we're now operating on many levels. So we're operating on the level of the client, the level of the setting, which includes providers, staff, and directors. But I think the actual process of receiving our feedback and then adapting is quite comparable. It's just more units of analysis.
Great,
And,
thank you.
oh, so I should also say that it's also then informing adaptations to intervention itself, but also adaptations to what implementation strategies you use. And so there's been a big push within implementation science to be very mindful and thoughtful about the implementation strategy that you use and making sure that it maps onto the determinant of implementation that you've identified.
Very nice. Well, we're at the top of the hour, so we should probably wrap up. Fantastic presentation, Jessica. Just as David said, I think you really demonstrated your breadth and depth of knowledge in very interesting and important research areas. And thank you so much for providing us with this informative lecture today.
Thank you.
Wonderful job, Jessica. Nice
Thank you,
work.
David.
Good to see everybody.
Good to see everybody. We'll talk to you all soon.
All right.
Bye.
Bye.
Bye-bye.